good health. Before I start my presentation, I would like to thank Professor Mesut and my distinguished colleagues. My presentation will be about the choice of pharmacotherapy, alternatives in comorbid mood disorders. One disorder, when added on to the second disorder, when the two disorders get together, the course of the disorder, the treatment of the disorder, or the prognosis of the disorder is influenced negatively. These negative influences increase the severity of the disorder and have a negative impact on the course of the disease. In substance dependency, comorbidity is something that we see very frequently. According to DSM, mood disorders are analyzed under two headings: depressive disorders and bipolar disorders. I'm going to go through the epidemiology first of all. Substance dependency and comorbidity is covered under the heading of epidemiology. ECA study and NCS study are the two studies that stand out. When we look at these studies, we see that mood disorder patients, lifelong substance abuse is about 32%. When we think of it in terms of bipolar disorder, it reaches 60%. It's a very common entity. Depressive patients, in comparison to those without depression, substance use is twofold increased. Bipolar patients have a sevenfold increase in comparison to those who do not have bipolar disorder. Of course, dependency is at the core of this picture. People with dependencies or substance abuse, what about it? Alcohol dependency is about 60 to 70%. Bipolar alcohol dependency is about 68% in bipolar disorder. In depression, it's 20 to 67%. A recent study, a recent publication, these are male patients coming to a substance abuse center. This was a study thinking about the comorbidities of the patients, and they scanned the patients according to the comorbidities. About 30% of the patients were reported to have bipolar disorder. Interestingly, the cases that they have detected as bipolar, half of these cases were not diagnosed with bipolar in the past. They were either diagnosed with anxiety disorder or attention deficit disorder, etc. 2/3 was type 1, 1/3 was type 2 of the bipolar disorder patients. Why is comorbidity so common? What is it with the etiology? There are various hypotheses. One of the hypotheses is in order to, they use it for self-medication, they say, and the individuals with the genetic disposition tend to use substances more is another view. Another view, frequent epileptic seizures cause sensitization. The sensitization induces more substance use, and the more substance use creates a tendency for comorbidity. And the third view is a common genetic pathway. We know that in substance use and substance dependency, there is a genetic background which is shared with mood disorders. Impulsivity, we know that is a part of bipolar disorder and also substance use. And there are genetic grounds for the impulsivity. What are the results of comorbidity? The clinical course is worsened. Both of the disorders tend to become chronic. Treatment is more difficult. There is a risk of mixed episode and rapid cycling, hospitalizations are more frequent, and the suicide risk is increased because of the comorbidity. Maybe the scales should be used, scanning should be conducted more carefully to pick out these comorbidities, after which we have to start treatment. I want to talk about depression first, after which I will talk about bipolar disorder in terms of treatment. What can we say about depression? Depressive patients, it is said, do not start too early, wait for the detoxification. Because withdrawal symptoms overlap with depressive symptoms and you might misdiagnose the patient. That's why you have to wait, they say. But of course, if the depression is severe, there are suicidal thoughts and the risk is increasing. And the depressive symptoms are not weaning out in time, or there's a family history, then of course we can start antidepressant treatment earlier on. Generally speaking, antidepressant treatment in alcohol-dependent people is more effective in comparison to others. With the antidepressant, both the depression is improved and the alcohol dependency is improved, but the effect is moderate. We shouldn't expect a very positive effect. What about SSRIs and TCAs? TCAs seem to be better, seem to be more effective, but all the literature says first choice SSRI because tolerability and adverse effect profile is better. In our country, we do not have monoamine oxidase inhibitors, but it is advised not to use monoamine oxidase inhibitors. Methadone during continuation treatment plus an SSRI is reported to be beneficial. Bipolarity. Substance dependency and bipolarity. In choosing treatment, you should choose something that will affect the both disorders primarily. After which you can choose naltrexone, disulfiram-like substances which are specific for substance use, substance dependency. Of course, both disorders, there are, when we talk about drugs which are used in both disorders, there are the atypical antipsychotics and the stabilizers and the mood stabilizers. Lithium is number one among mood stabilizers. Substance abuse and the studies conducted with adolescents with substance abuse, lithium has been reported to be beneficial. Classical information. If a patient has substance abuse, the effect of lithium on mood is decreased. Another study with cocaine-dependent patients, there are ambiguous results. Some studies report benefit, some studies report no benefit. After lithium, almost everybody reports positive findings with valproate. Valproate decreases alcohol consumption, plus has positive effects on mood. When compared with lithium, its tolerability is better. Thirdly, carbamazepine, another classical drug. It's used mainly with cocaine-dependent patients, and it has been shown to decrease cocaine consumption. Gabapentin is a more recent drug. We do not have much data about its use in an isolated fashion. It is used more with patients of alcohol abuse plus anxiety. It is used as a supplementary treatment, additional treatment. Lamotrigine is another agent we are using more and more commonly, especially with cocaine patients. This decreases craving, has positive effects on mood. In bipolar patients with family history of substance abuse, lamotrigine has been shown to be effective. Quetiapine has been talked about in the morning sessions, decreases cocaine and alcohol craving, improves psychotic and depressive symptoms, and decreases the cannabis use of schizophrenia and bipolar patients almost to completion. Does it have a dependency profile? Is another question. We do not have such an observation. We have antisocial patients because I work at the military setting, and the antisocials generally use substance more frequently. In the old days, when they came to us, the antisocials, they used to ask for acetone, but now they're asking for quetiapine. This is an interesting observation I wanted to share. What about aripiprazole? It's said to decrease cocaine and alcohol craving and consumption. It's said to have positive effects on depressive, manic, and general psychiatric symptoms. Topiramate, oxcarbazepine, modafinil are the other agents. Not many studies are reported with these agents, but topiramate has been used with substance dependency. Positive findings have been reported. With bipolar patients, the question is, can it be used for both? Oxcarbazepine, this is a carbamazepine derivative. I have a problem with my slides. Oxcarbamazepine is a carbamazepine derivative, and carbamazepine is said to decrease cocaine consumption with a side effect profile which is better than carbamazepine. Can it be used with a comorbidity situation? That's another issue that's being considered. Modafinil has been used with cocaine dependency. It has been used to alleviate. These drugs, which are beneficial for these two disorders, after considering these drugs, then now it's time to consider the drugs which are specific for alcohol and substance use. Naltrexone has been studied with alcohol-dependent patients. There are positive findings. Some patients say that some patients they have difficulty in tolerating naltrexone. Naltrexone is new in our country. I believe we will have more experience with it in the future. Buprenorphine, again, there is no study about it, but I believe it can be used with this patient group. Disoproam is being used with alcohol-dependent patients. With bipolar patients, these patients are very impulsive, and because of this impulsivity, disoproam might be found to be risky because it can cause alcohol disoproam reaction. Disoproam causes dopamine beta hydroxylase enzyme inhibition. Could this cause an exacerbation of psychosis? Perhaps because of these reasons, we should shun away from disoproam. I wanted to look at the episodic perspective of the bipolar disorder. If the patient comes to you in manic episode, plus alcohol or intoxication, then you should use atypic antipsychotics. Perhaps quetiapine could be one of them, or aripiprazole, or valproate, or carbamazepine can be used, I believe. If the patient comes to you in a depressive mood, depressive episode, primarily you might prefer not to start any medication. If you are to start medication, if the patient is going through a bipolar depression, then you can start SSRIs plus mood stabilizers, or lamotrigine and quetiapine can be considered. Thank you for your attention.